Hello, this is Hemodynamic Monitoring. My name is James Inciardi. I usually like to introduce myself and my background at this point, but instead, let's not waste any time. Let's just get to the lecture. There we go. The objectives for this lecture is to describe three methods of hemodynamic monitoring, including vital signs, arterial catheter, and central line. Use strategies in rapid response calls to garner more information about your patient quickly, and discuss arterial pressure waveform abnormalities and state their significance. Okay, so let's start with the basics here. We all know these numbers. These are the normal values for heart rate, blood pressure, and respiratory rate. And I've put a few things in here that could cause some more abnormalities, these vitals, but of course these are going to be a vastly incomplete list. As a respiratory therapist, you're going to be expected to respond to calls, all the rapid response calls in the hospital. And so here's a little trick I learned from my days working as a paramedic. When you first meet your rapid response patient, the one thing I really want you to do in your first 30 seconds is to get a radial pulse. Just take their hand and feel for a radial pulse. This is what's called a paramedic handshake. This will tell you a lot about your patient in a very short amount of time. Heart rate fast or slow? Is the heart rate fast? Well, then you have to suspect the patient might be going into shock or a drug overdose, or it may just be anxiety. Also, is there a radial pulse? If there's no radial pulse, then that indicates the blood pressure is below 90 systolic. And that's one way you can tell how sick your patient is. If you can get all that information just by feeling for a radial pulse, it only takes a few seconds. Really good idea to do it within the first 30 seconds of meeting your patient. It's a little trick I learned a long time ago, and it's helped me many times. Lastly, the respiratory rate. If a patient is going to have a problem, the respiratory rate is the first clue that something is wrong. A fast respiratory rate should be very alarming to you. Even if they are breathing but they seem to be maintaining okay, they're going to tire out. So you better not ignore a fast respiratory rate. Last thing I want to mention is that when you're responding to rapid responses, when you're considering your differential diagnosis, think to yourself, what is the first thing that's going to kill this patient? Based on this, and based on your signs and symptoms and the patient history, if you have it, you'll be able to move your questioning and your assessment based on what's going to kill your patient first. For example, if you have someone with a high heart rate and no radial pulse, but they're conscious, you might think cardiac arrhythmia. And if you see that they're in sinus tach with no ectopy, well, then you might think bleeding. Is a rigid stomach, pedal pulses. So you just might move on from there. It's a lot easier if you have patient history to guide you towards the most likely diagnoses. So now we get into pressure waveforms. You can get a lot of information from the pressure waveform.
Delta Airlines is paging a passenger that just came off a flight from Las Vegas.
I'm in the airport right now. That's why if you're hearing that. Anyway, let's talk about pressure waveforms. And you can get a lot of information from the pressure waveform, kind of like the same way that you look at an EKG and you can see patient has hypertrophy of the aorta and ventricles, a bundle branch block, and so on. I find it kind of interesting, actually, to be able to sleuth these things out of waveforms, even if they have no direct clinical significance. I hope you find it interesting too. Anyway, let's look at the pressure waveform and so we can see like a lot of clues. For example, if the upstroke of the waveform indicates the upstroke of the waveform indicates systole. If it's angular, which means there's more horizontal and less vertical, that means the patient has aortic stenosis. If the patient doesn't have aortic stenosis and the upstroke is angled, well, then that indicates the patient's heart contractility the ventricles have decreased contractility. You can also tell a lot about peripheral vascular resistance by looking at the downstroke of the pressure wave. A flatter downstroke indicates more resistance. The area under the curve is another thing to pay attention to. The more area under the curve, the greater the stroke volume. And here's one other thing you can try to look for. Look at the behavior of the arterial line tracing in relation to mechanical breathing. When the tracing dips down in the expiratory phase, well, that's a sign of hypovolemia. It's usually a very good indicator, pretty reliable. Decreased afterload is also indicated when the tracing increases during the inspiratory phase of the vent. Okay, so just quickly, let's talk about central lines. They're inserted through the right internal jugular vein, ideally, though there are other landmarks where they can be placed. It can go into the right subclavian as well, but that's a little more difficult to place the central line where it needs to go. Most commonly, the PA catheter ends up in the right inferior pulmonary vein, ideally, because that's where the most flow is. Okay, PA pressure is a good indicator of right ventricular filling pressure, which is indicative of volume. Now remember, the system has to be zeroed appropriately. The transducer has to be centered at the fourth intercostal space, or the phlebostatic axis. Okay, central venous pressure. Normal central venous pressure is 4 to 10 mmHg. If this number is low, then that could indicate hypovolemia or sepsis. If it's high, that could indicate any number of cardiac, pulmonary, or extrathoracic causes. When using CVP to ascertain hypovolemia, you can judge how much fluid to give. As you're giving fluid, the CVP will remain low, but then shoot up very quickly when the right balance has been achieved. And you don't want to overdo the fluids for obvious reasons. You can use a PA catheter to draw mixed venous O2. A normal value should be around 75%. If the number is lower, that means that the body is pulling more oxygen out than it should. This could mean that the body is very thirsty for oxygen, or it could mean that the blood is not moving as fast as it should. So the blood remains in contact with the cells longer, allowing them to pull more oxygen out than normal. If you have a central line and an arterial line, you can pull a blood sample out of the central line and the arterial line at the same time. This gives good information because then you can know the O2 sat as the blood leaves the heart, and you can know the O2 sat when the blood returns to the heart. So you can calculate a lot about cardiac function. Mixed venous saturation is used to assess adequacy of perfusion. It's affected by O2 delivery. Mixed venous pressure is usually around 40 normally. By the way, the Fick equation, which is used to calculate cardiac output, is, as you see right there, VO2 equals QX multiplied by CaO2 minus CVO2. So you can see why the sequential gases earlier that I mentioned are important. Wedge pressure is indicative of left ventricular end diastolic pressure, and therefore is a measure of left ventricular preload. This number is affected by compliance, intrathoracic pressure, and catheter position. It's best to use this number to monitor changes, not as a concrete number. So you don't say, oh, it's high or it's low or whatever. Well, you could, but really it's just, you're just monitoring it over time. So a low reading would indicate it's low compared to earlier in the day or earlier in the shift or whatever. All right. I don't really like to talk about math. I don't like math, and math doesn't like me. But one thing that I really like about math is using math to look up how patients are doing. It's fun to break out equations and to look at how the numbers match up. So here's a few numbers you can use. Stroke volume. The equation here will give you the stroke volume in milliliters. Cardiac output times 1,000 divided by the heart rate. Next we have stroke volume index, and this is a little bit better because it takes into account the size of the patient. Next we have pulmonary vascular resistance, and then systemic vascular resistance. And then we can talk about left ventricular stroke work index. This is a good indicator of contractility. It's used to track interventions, and there you see the equation right there. All right. Well, that's the end of my presentation. I thank you for listening, and I hope you enjoyed it and thought it was informative. If you have any questions, please feel free to email me on the Boise State website. Thank you very much.